CO2 can also cause a change in the oxygen hemoglobin dissociation curve. Again, in red is the normal curve. Blue is showing a right shift, and the green one is showing a left shift. If you look at the CO2 values now, you'll see that the blue curve shows a partial pressure of CO2 at 61 millimeters of mercury. The normal for CO2 is about 35 to 45 millimeters of mercury. So this is significantly higher. When would the cells in a tissue bed be making more CO2? When they are having a higher metabolic rate. So as they are more metabolically active, not only are they consuming more oxygen and generating more acids, as we saw on the previous dissociation curve, but they are going to be making more CO2. And CO2 is another type of acid. So taking all this together, there's going to be a right shift, and that means a reduced affinity. The iron is more likely to be in a tensed position and more likely to give off more oxygen. Again, a perfect setup. If the cells have more metabolic needs, more metabolic demands, then they are going to create a tissue bed with an environment that causes the hemoglobin to become more tensed, or the iron in a more tense position, I should say, to give off the oxygen. Temperature also causes shifts in the hemoglobin dissociation curve. So again, in red, you're going to see normal oxygen hemoglobin dissociation curve, and in the blue, you are seeing a right shift, and in the green, a left shift. The right shift is occurring when temperature is higher. When might tissue beds have a higher temperature? When they're more metabolically active, or say, when skeletal muscle is contracting. That generates heat as a byproduct. We also can see a higher temperature when we're talking about someone with a fever. The tissues at a higher temperature are more metabolically active. You got to be thinking that more acids will be produced, more CO2, temperature is higher. Taking all those together, clearly we are going to see a right shift in the oxygen hemoglobin dissociation curve. And that means the iron is more likely to give up its oxygen. It's going to go into that tensed position where it, quote, flicks the oxygen more readily towards the tissues. Lastly, this is the slide I was referring to when I was comparing the fetal hemoglobin to the adult. That is why I said the fetal hemoglobin had a higher affinity for oxygen than the adult. This 2,3-DPG is a byproduct of red blood cell metabolism. Red blood cells, of course, cannot use aerobic means to generate ATP. They have to use anaerobic means. And one of the ways they generate ATP is through a pathway called the hexose monophosphate shunt. We won't get into that pathway, but suffice it to say, the RBCs don't make robust amounts of ATP using this pathway. When RBCs have a low oxygen content, they're going to be making more 2,3-DPG. This is going to make the hemoglobin curve shift to the right. It's a lot like an internal regulator that the red blood cells have that can cause them to give up more oxygen, or, in reverse, to bind more oxygen. Now, if you look at the top picture over the dissociation curve, I want you to find those black ovals that represent 2,3-DPG. You'll notice that it's binding in the beta-globin chains. The beta-globin chains is where 2,3-DPG can bind, and this is the reason why it causes the adult hemoglobin to have a reduced affinity for oxygen. What globin chains does the fetal hemoglobin have? Alpha-2 and gamma-2. Gamma-2 globin chains do not have a binding site for 2,3-DPG. This is the reason why I said in vivo, inside a red blood cell, the adult hemoglobin is right shifted compared to the fetal. It is because it is more sensitive to the 2,3-DPG, because 2,3-DPG can bind to beta-globin chains, but it cannot bind to gamma subunits. Again, this right shift is seen with the adult hemoglobin, and a left shift with the fetal, because the 2,3-DPG cannot bind to fetal hemoglobin. Let's move to the synthesis of the porphyrin ring. The porphyrin ring actually is generated in mitochondria. The mitochondria use succinyl-CoA and glycine to make pyrrole groups, shown here in the middle picture. 4 pyrrole groups assemble to form a protoporphyrin ring. The protoporphyrin ring can be seen in this green circle. If you take the iron out of the center, you would have that protoporphyrin ring. And when you add iron to the ring, now we can call this heme. So the picture in the green circle is really showing you heme. When you add the heme to a polypeptide, then you have a hemoglobin chain. It can be either the alpha or the beta. 2 alpha chains, 2 beta chains in the adult hemoglobin, of course. The globin chains are synthesized in the cytoplasm. They are a product of gene expression. The protoporphyrin ring is synthesized in the mitochondria, and it is basically transported out of the mitochondria to the cytoplasm where iron will bind, and now the heme group can be bound to the peptide chains. Let's review iron very quickly because I already did this in another lecture. I'll remind you that we get iron from our diet, and a very good source of iron, if you are not into eating your green leafy vegetables, is actually using an iron skillet to cook your food in. You'll get some of the iron straight from the pan. You absorb your iron from your diet, and it's going to bind to a plasma protein called apotransferrin. And once the iron binds, we drop the prefix apo. The iron will be deposited to the cells of the body that can store iron, particularly the liver, that's very good, or cells in the bone marrow. Apoferritin is a cellular protein, and once again, when iron is bound to it, we then call that protein ferritin. We drop the apo. The way we want to store iron in our cells is in the ferritin form. From iron overload, which could happen from profound hemolysis or lysis of red blood cells in a very extreme rate, we can then see iron stored as hemosiderin. Hemosideric crystals are very insoluble. They precipitate out of the cytoplasmic water, and they're toxic to the cells, and the cells will die. The type of iron that we utilize to bind to oxygen is the ferrous form. That's the reduced form, meaning it's less positive compared to the ferric form, which is the oxidized form in the +3 state. The ferric form has lost an additional electron. That's why it's +3. The ferric form in hemoglobin is called methemoglobin, and this cannot bind to oxygen. Now, all of us at any given time, we have some of our hemoglobin with iron in the ferric state. So our red blood cells, they are carriers of oxygen, and oxygen is a reactive oxygen species. It can certainly generate free radicals. These free radicals can oxidize iron, turn it into the ferric state. So we all have methemoglobin in our red blood cells at any given time, but our red blood cells are equipped with enzymes that can give an electron back to that iron and reduce it back into the ferrous form. I'm going to tell you about a specific type of anemia where someone lacks this ability to reduce iron, and this deficiency is called G6PD deficiency, and you'll learn more about that in a future segment. Speaking of iron and storage of iron, there is a condition known as hemochromatosis where a person has a mutation in an iron regulatory gene. This leads to increased absorption of iron from the gastrointestinal system. As a result of this, there's a lot more iron absorbed, about 30% of what is ingested, and normally we only absorb about 10% of what we ingest. What sort of signs and symptoms would we have in a patient? Well, with this iron overload, we're going to have a lot of hemosiderin causing a lot of cellular death. We're going to see that organs that are capable of storing iron are going to be at risk. First of all, the liver, heart, and pancreas would be some of the biggies. They are not the only ones. These organs will start to fail. We'll see elevated liver enzymes, cirrhosis of the liver, which is when the liver is being replaced by scar tissue. Hepatomegaly means enlarged liver because the cells are storing copious amounts of this hemosiderin. The heart is going to have arrhythmias. In the pancreas, the iron is going to destroy the beta cells, and this person will likely present with diabetes mellitus. The person is also going to present with bronzed skin, and we call this disorder bronze diabetes. And it's because of the diabetes caused by the hemochromatosis. In general, it's just going to cause profound organ failure. The patient will have pain in the joints and abdomen and also fatigue. Maybe you're wondering how common hereditary hemochromatosis is. It's actually a relatively common inherited disorder. About 3 to 5 people per 1,000 in 1,000 of Northwestern European ancestry are homozygous. As I said before, this is a problem with increased absorption of iron from the diet. It's an autosomal recessive disease, and it becomes clinically significant only in the homozygous individual. If left untreated, hereditary hemochromatosis, or HH, can be fatal. The excess iron is stored in the liver, where it becomes toxic, of course. There is also pituitary and gonadal failure and arthritis. That would be the pain in the joints that I was telling you about. The disease hardly ever becomes apparent before the individual enters their 3rd decade of life. Women are relatively protected as long as they are premenopausal, because their monthly menstrual flow keeps total body iron stores relatively normal. Treatment is reminiscent of the medieval approach to disease, which is to remove or phlebotomize 1 or even several units of blood on a regular basis, and this is to help bring the iron overload back down to appropriate levels. After this initial phlebotomy, most patients require phlebotomy once every few months or so to maintain their low iron stores. The role of this mutation in the HFE gene is not yet clear. Attention has been focused on hepcidin, a recently identified hepatic protein that appears to play a critical role in the regulation of body iron stores and duodenal iron absorption. You see, normally increased body iron stores reduces iron absorption. Hemochromatosis represents an inappropriate high rate of iron absorption relative to body iron stores. In other words, you're supposed to be in negative feedback. If your body iron stores are high, then you should have decreased GI absorption of iron. In hemochromatosis, we are seeing that the iron stores are high in the body, but yet there is still a high absorption rate. The hepcidin is supposed to down-regulate iron absorption, and hemochromatosis may represent a defect in the regulation of hepcidin. Again, we are not really sure of the relationship between HFE gene and hepcidin itself. Again, a quick review. We remember that erythropoietin is a hormone. It's primarily released by the kidney, about 90%, with some token amounts coming from the liver. The kidney is the organ that detects hypoxemia, and hypoxemia is low oxygen content in the blood. If there is renal failure, then we would have decreased EPO, and a patient would present with anemia. So you need EPO from the kidney. The actions of EPO increase stem cell mitosis, so the hemocytoblasts are replicating and dividing more frequently. There is a greater release of reticulocytes into the cardiovascular system as well. And there is an increase in red blood cell number in about 5 days. We do have a recombinant human EPO. This has led to a lot of sports venues having a problem with people doping on EPO, because a person with more red blood cells can carry more oxygen, which means they are in aerobic phases longer, and that can mean the difference between winning a race and losing the race. So a lot of the sports venues have put a cap on hematocrit as a result, and many of them say something like, if your hematocrit is more than, say, 50 or 52%, then you cannot compete in this activity or competition. Here is the feedback loop that allows the kidneys to regulate red blood cell numbers. Again, the kidneys detect hypoxemia. They have oxygen sensors. When they detect a reduced amount of tissue oxygenation, they release EPO. This will stimulate the hematopoietic stem cells, the hemocytoblasts, and this will promote more of the daughter cells entering the red blood cell lineage, meaning more cells will enter as pro-erythroblasts. And this will lead to more reticulocytes released into the bloodstream. And then once they mature, this will of course lead to an increased red blood cell count. What could reduce oxygen levels in the blood? Many things. Low blood volume, of course, because then you would have reduced oxygen carrying capacity. Anemias, especially those where you have reduced red blood cells. Low hemoglobin, poor blood flow, or pulmonary disease. Maybe in the pulmonary disease you can't get oxygen to cross your respiratory lining. So all of these are possibilities. I also have a picture up here of a mountaintop. Obviously, if you were going to go to higher elevations, there would be reduced oxygen content in the atmosphere, and this too would be detected by the kidneys and stimulate EPO release. Let's talk about red blood cell removal. The red blood cells have a lifespan of about 120 days. They do not have any cellular organelles, so any damage they sustain in those 120 days, they would have no way of repairing that damage. They are subject to incredible mechanical stress. They have to fold over to get through narrow capillary beds, and they're carrying oxygen. So that means they're going to sustain a lot of free radical damage. Even though they do have enzymes to help quell the amount of free radicals and the damage that they do, eventually the damage does accumulate. Their membranes become more fragile. They are not as flexible. Eventually, when they are traveling through the portal circulation, when they get into the liver and or spleen, there are reticular fibers, and these reticular fibers are like a spider web, and that's why I have this picture of a chain link fence up here. As long as the red blood cells are flexible enough, they can get in between these reticular fibers. If, however, they have inflexible cell membranes or have a lot of cross-linking of proteins and phospholipids, they're going to get hung up on these reticular fibers, and then the macrophages will come and phagocytose those red blood cells. What happens to the hemoglobin? Well, parts of the hemoglobin molecule can be recycled, but one part in particular, the porphyrin ring, that's a waste product. It can't be recycled. So in this picture in the top right, I am showing you the beginning stages of red blood cell destruction. You see a large macrophage has already phagocytized 4 red blood cells. You can actually see them inside the macrophage's cytoplasm. This is a similar picture to the one in your book showing hemoglobin destruction. What happens is, well, look in the burgundy circle over here on the left of your screen. That's representing a senescent red blood cell. A macrophage, either in the liver or in the spleen, will phagocytose that red blood cell. Inside the macrophage, what's going on? The globin chains will be liberated. The heme will be liberated. And from the heme, the iron will be liberated from the porphyrin ring. The globin chains can be recycled. They can be hydrolyzed into free amino acids, which can be used by other cells in the body. The iron can also be liberated from the macrophage and bind to the plasma protein apotransferrin to turn it into transferrin, which then can be dropped off to other cells in the body, the iron I should say, and then the iron is stored as ferritin. That's the good way to store it, remember. If there's too much of this red blood cell destruction, then there can be iron overload, and this can lead to hemosiderin. Now the porphyrin ring, it's shown up here, can be converted into free bilirubin. And the free bilirubin is also known as unconjugated bilirubin. It's not very water soluble at all. When it's released into the bloodstream out of the macrophage, it needs a carrier. It needs albumin. Albumin envelops this free bilirubin and makes it more water soluble. It is then transported to a different cell, a hepatocyte. That free bilirubin is now going to be conjugated to glucouronic acid. Conjugate meaning to marry or to bring together, to bind. This is a covalent bond basically between the two molecules. And then you get conjugated bilirubin. This is released into the bile through the bile duct. Glucouronic acid makes bilirubin much, much more water soluble. So it is released into the bile, into the small intestine, and their bile is used to emulsify fats. The conjugated bilirubin that stays in the intestine will be converted into something called stercobilinogen by bacteria that are found normally in your gut. Some of the conjugated bilirubin, because it is so water friendly, will actually be reabsorbed by the GI tract. Now, this is supposed to be waste. We're trying to get rid of it. And here our body is reabsorbing it. Well, that reabsorbed conjugated bilirubin will be freely filtered by the kidneys. That conjugated bilirubin, when it's going through the nephron, will ultimately be converted into urobilinogen. So these conjugated bilirubins can be excreted from the body as either stercobilinogen or urobilinogen. And I should tell you that there's a color associated with them. The stercobilinogen is the reason why your feces are brown in color. If you have a bile duct obstruction and you can't release your bile and can't get rid of your conjugated bilirubin that way, your feces will actually be a clay color. The urobilinogens give your urine a bright yellow color. If there is a bile duct obstruction, then that means the only way you can get rid of your conjugated bilirubin is through the renal system. So again, a patient who has that will have clay-colored feces, but also have bright orange urine because of the increased amount of urobilinogen.